I'd like to thank the BNPA for this unexpected award. It doesn't seem too long ago since those first meetings when there was just a handful of people in the audience, mainly psychiatrists, at the London Zoo, Queen Square, the Maudsley. I remember those meetings really very well. So thank you to the BNPA. I have some declarations. This is all, what I'm going to tell you about is all true, believe it or not. And Soulful Neurology is not neuropsychiatry, but it's moving in the right direction towards neuropsychiatry. So the neurologists I encountered during my undergraduate training at what's now called the Royal London Hospital combine the precision of mathematicians, the scrupulosity of entomologists, and the solemnity of undertakers. For these great men, and they were all men in those days, all neurologists were men in the 60s, there was no such thing as unexplained symptoms or psychosomatic disorder. These were terms that reflected woolly thinking, lack of accuracy, and a sloppy neurological technique. There were no difficult cases for my teachers, only fascinating cases. Through a process of reasoning, which as a medical student I really didn't understand, but it left little to the imagination, they pulled black swans and zebras from their hats. Diagnosis was very important for neurologists at that time. It still is, of course. It seemed in the late 60s as a medical student as if it was only a matter of time before all disorders of the brain would be worked out and categorized in terms of anatomical, electrical, and chemical connections. And this rational approach drew me in, and I selected diseases of the nervous system as my specialist subject as a medical student, thanks to my teachers. Now, I started my neurology training at University College Hospital in 1975, and one of my teachers was Dr. William Goody. He emphasized to me that my clinical training would be long and arduous. I would need to learn to listen, learn to observe, and learn to infer. Those were the three key things. And that my main teachers would be my patients. He encouraged me to note and record the unusual and place it on permanent record, which I'm not sure teachers these days do this to registrars. So as if I thought I'd seen something new and interesting, write it up, record it. And he also encouraged me to work on my writing style and avoid what has been called disparagingly municipal decorated Gothic, which contaminates much of medical writing, even today. He also taught me that neurology was very serious. We were dealing with brutal illnesses, but it should also be fun, and even at times romantic. Unlike his own teacher, Sir Francis Walsh, he also believed that there was one brain, and that brain belonged to neurology and to psychiatry. It was for both of us, both specialities, even though he was a neurologist at Queen Square. So you saw what he wrote, told me to read, which I wondered what planet I was on when I started my training, but I already read some Sherlock Holmes, and I'd been drawn to neurology by its material rationalism, so I could engage emotionally with Sherlock Holmes, and I did what I was told and read as much of Sherlock Holmes' canon as I could. Those of you, Holmes has survived all the Victorian heroes that I was brought up with. They've all been forgotten, but Sherlock Holmes has become alive and is still very popular with young people. He's a contradictory mythical figure, the hero of reason, and perhaps that's why he's still very popular. He used his luminous intellect to solve seemingly insoluble riddles. And Doyle, his creator, devised a universe in which all human mysteries could be made to surrender their secrets to the preternaturally tuned intellect. And he combined that with spiritualism, in which grief could be assuaged by a belief that you could have eternal life and in contact with the dead. So this is, of course, a universe that is totally alien to medicine. And if you start talking about these things in medical circles, your career may not go very far. And yet, surprisingly, Sherlock Holmes has been of great interest to many, many physicians throughout the ages and still is. So what is it that my teacher, William Goodit, was trying to tell me? Well, it's interesting that forensic science or medical legal jurisprudence grew up at the same time as neurology at the end of the 19th century. So these were two new specialities developing around the same time. And both neurologists and criminal detectives seek hidden truths and meanings out of chaos. And they both rely on a rigorous technique. So Maudsley, Henry Maudsley, David Ferrier, were forensic doctors as well as psychiatrists and neurologists. So there are parallels. And I think what Goody was doing was I was an insecure young resident, not certain of my future career, and he was trying to draw me into the romance of neurology, if you like, and provide a bridge through Conan Doyle to the Sherlock Holmes of neurology, who was William Gowers. So I think that's what he was doing. Now, those of you who are Sherlock Holmes fans will know that the character of Sherlock Holmes was based on Joseph Bell, a surgeon at the Edinburgh Royal Infirmary where Doyle trained. And Bell was an expert on instant or spot diagnosis, which of course is frowned upon now in the membership exams. But spot diagnosis may be frowned on, but observation and inspection is still very important, at least in neurology. And Bell was able to glean from a woman who came to his clinic with a child that she was from Burntisland, a village close to Edinburgh, through her accent. She travelled via Inverleith Road because she had red clay on her shoes and the road was being dug up at that time. And the child, she had another child because the jacket on the child was too big for the child that came with her, and that she worked in a linoleum factory because of dermatitis on the fingers. And if you read Sherlock Holmes, and then you turn to the lectures that Gowers gave to the medical students at UCH, which are all published in the BMJ and the Lancet in the 19th century, there is an uncanny similarity in the way Holmes talks to Watson and the way Gowers talked to the medical students. Did you notice him as he came into the room? If you did not, then you should have done so. One of the habits to be acquired and never omitted is to observe a patient as he enters the room, to note his aspect and his gait. If you did so, you would have seen that he seemed lame. The patient had tabes dorsalis with a locomotor ataxia, and you may have been struck by that which must strike you now, an unusual tint of his face. So his face was blue, the patient, because he'd been treated with colloidal silver, which was a treatment for syphilis in the 19th century. So he had argyria. So this is Gowers reminding us about observation. And if you read his manual, he'll emphasize very much the difference between seeing, looking, and observing, and going with that, the difference between precision and laxity. The difference is absolute, and absolute is the enduring influence. And of course, how hard you look at a patient depends, it's not always the same. You know, sometimes you don't need to look at all or hardly need to look at all. And other times you need to look as if you were taking a photograph, you know, with a really intense gaze. So this is a matter of judgment. And as Gowers pointed out, wherever judgment happens in medicine, error is likely to follow. That's the profession we're all in. So this is, Gowers was very much a visual, as was Charcot in his work. And a painter too, he drew and illustrated his books. Then of course we can learn from Leonardo of the three types of people, those who see, These are visual people. There are not many of them are artists, perhaps, some photographers. Those who see when they are shown, and that's most of us. So I could never detect slowing of vertical saccades in progressive supranuclear palsy until John Lee, a neuro-ophthalmologist at an American Academy meeting, actually took me aside and showed me how to do it. And once he'd shown me how to do it, I could see. And then there are people who never look. You know, they've got their heads on the computer screen, don't look up, don't talk to their patients, or don't observe them while they're taking the history. And one of the other pieces of advice that William Goody gave me when I was working under him was, he said, why don't you take if there's no cases on the ward, why don't you take the students around the circle line and see what you can see? So those of you who've done the circle line will know it takes just over an hour to get round, so it's perfect for a teaching session. So I paid for the tickets. We split up into groups, so there's 2 or 3 in each carriage, so we would maximize our yield for the morning. And no photographing, no ogling, no bystander diagnoses. The purpose of this was to improve looking. And we saw a hell of a lot, and then we'd come back to the Ward 5-2, to the top of Ward 5-2, and we'd discuss what we'd seen. We saw a lot of psychiatry, you know, a lot of the body language of psychiatry. We saw seizure one week, which I've never seen in the hospital at Queen Square. So we saw a lot of interesting things. And the purpose of this was not diagnosis. We weren't trying to make diagnosis. I was trying to get them to look as if they'd witnessed a crime. So as if you were a witness to a crime, describe it, describe it. And that was the purpose of doing it. And then later on, when I got into movement disorders, I used to travel in from North London on the Northern Line. This is a picture of the Northern Line in the 80s, so you can see how things have changed compared with traveling in now. Look at the people reading newspapers, all white faces. And what I did was keep a book of movement disorders that I saw. And I saw a lot of things that I never saw in the clinic. I might have seen them if I'd been in casualty, but I never saw them in neurology clinics. And I recorded them. I didn't necessarily make the diagnosis at that time. But I found this book quite recently and got it out and started to look at what I'd written down and put some names to some of the things that I thought I'd seen at that time. So, for example, I saw a young man with dilated pupils, bitten nails, moving his lips like this, very anxious, very nervy, and, as I said, dilated pupils. And probably, in hindsight, he was on speed or chronic amphetamine use, which I'd never come across in my textbooks or anything. So I saw things there that I would never see in clinic. Now, of course, you have to listen, you have to observe, but then you have to infer. And Sherlock Holmes was very keen to tell Watson that he didn't guess, but in fact he did. It was a kind of guessing. So he wasn't using inductive reasoning, the method that we use if we're working in the laboratory, the method of science. I have observed the world, recorded my experiences, and the data shows that all swans are white. Conclusion, all swans are white. And he wasn't using deductive reasoning, which is what mathematicians use, very powerful logical necessity, certain. All swans that have ever been seen are white. This is a swan, so it must be white. So how did Holmes join up the dots? And this slide kind of describes some of what he tries to do. So if he saw a flotilla of white birds with big wings in the sky flying in a V, he would probably say, on the balance of probabilities, these are swans. And that's the business of medicine. So those of you who are doing science, proper science in wet labs, and then going into the clinic, you have to change hats, you know, because it's really a very different way of thinking. And Holmes eventually, as I went on through my career, helped me to understand that better through reading his writings. Now, one day on the ward later on, I was very keen to show off my new Sherlock Holmes skills, and I told the nursing sister to keep the patient in the bed. It was in a side bed. But when we got there, as happens more and more nowadays with ward teaching, no patient. So the patient had gone off for some tests or something. So undeterred, I decided to get the students to actually try and tell me what they could see based on what was present in the room without the patient. So the patient wasn't there. So, of course, this is slightly simulated, but and I've just made this slide relatively recently, but it was kind of like that. So you can see a comic. So, you know, of course, any age can read comics like that, but I think in those days, it was in the 70s, it might not have been unreasonable to say that this was a young patient, perhaps a teenager. Peak flow meter. Remember, it's a neurology ward. A patch, difficulties drinking, and these are ice packs. So, you know, I would have hoped that they might have suggested that the patient might have double vision, because there was a patch, that had some breathing problems, and some swallowing problems because of the thing. So you might be thinking of neuromuscular diseases, and particularly myasthenia gravis. So this was another kind of teaching exercise that we did in those days. Now, Holmes, as you know, had a genius for minutiae and specialist knowledge. So he was an expert on tobaccos, perfume types, shirt sleeves, thumbnails. And he was also, one of the first books I read, one of the first stories I read was The Adventures of the Cardboard Box, in which Holmes is sent an ear from a murdered person in the post from Northern Ireland in a box. And he says to Watson, "As a medical man, you are aware, Watson, that there is no part of the human body which varies so much as the human ear. Each ear is, as a rule, quite distinctive and differs from all other ones. Imagine my surprise then when, on looking at Miss Cushing, who was in front of him, I perceived that her ear corresponded exactly with the female ear which I had just inspected. The matter was entirely beyond coincidence. There was the same shortening of the pinna, the same broad curve of the upper lobe, the same convolution of the inner cartilage, in all essentials the same ear." So, and the ear is a very distinctive thing. Of course, as doctors, we don't spend much time looking at it. The only thing I'd looked at was the deep crease in heart disease things. Anyway, a few years ago, one of my research fellows on the Parkinson's ward at Queen Square said to me, "You know, this patient of yours, Prof, has got a funny face and funny ears." And I hadn't noticed personally, but she was pretty sure about it. So we went to see somebody at Great Ormond Street who was an expert on morphometry of genetic and chromosomal disorders, and showed the pictures, and the expert said, "Oh yeah, that's DeGeorge's syndrome, 22q deletion." We looked it up. It had recently been associated with adult onset Parkinson's disease. Many of you will know it's also associated with schizophrenia. So this was very interesting, and what she'd noticed was that the upper ear was squared, an increased fold of the helix, and a deep ear pit. So ears, take time to look at ears sometimes, and Morelli, who was a physician and an art connoisseur, used ears to determine art fake. So he looked at a lot of art, grandmasters' artworks, and by studying the ear, could say, first of all, whether it was Leonardo or Botticelli, but he could also pick up fakes. So the ear tells you quite a lot. And of course, many of you are psychiatrists, and you are the great listeners. We learn from you about listening, and we learn not to interrupt. So I just wanted to, and listening is difficult. Osler didn't write too much about listening. He wrote a lot about observation. So listening, deep listening, attentive listening takes practice and skill. So this was a patient who came to see me with his Polish girlfriend. This is 25 years ago. He was a 40-year-old plumber, Polish, who'd recently come to work in England. And the letter from the GP said that he had developed subacute Parkinsonism, over 8 weeks. It had come on very, very quickly and was getting worse. No drug history. We probed the drug history, no family history. A scan, head scan, didn't show anything. And he was desperate to work. So I'll just show you a quick clip of him, just so you can see that he's got Parkinsonism. So it was asymmetric. He had a tremor of the left hand, and you can see his movements are quite slow. He has difficulty finger tapping with a motor decrement on both sides. And his gait is of reduced steppage, a bit robotic with a flexion of the elbows. So he was desperate for treatment. So I gave him low doses of L-Dopa and arranged to see him again in 8 weeks after we'd got the results back and the scans back. When he came back with his girlfriend, he was normal. There was not a single sign of Parkinsonism. It had gone. Now that's very unusual. You know, L-Dopa is a good drug, but it usually doesn't get rid of everything so that you can't detect anything. And this had happened pretty quickly. So I didn't really know what was happening, except I was obviously very pleased that he was better. And then just as they were going, and this is of course something that as doctors we're all familiar with, the most important things that patients say to you are usually just when they're leaving the room, not when they first come in. Oh, by the way, doctor, I forgot to tell you this. So his girlfriend said to me, did he tell you, we forgot to tell you he's been on some herbal remedy which he's bought from a Chinese shop on Goode Street, this was at the Middlesex Hospital when we worked there. So it was just around the corner from the hospital. And he showed me the box, I think he showed me the box, which was in Mandarin. I didn't understand anything. It was the last appointment of the day, outpatient appointment of the day. So I said, come, I'll go with you to the shop. So we just walked out of the clinic and walked to the shop, which is here. This is the shop, is still there, I think, San Ling's. We went inside. He showed the box to the Chinese herbalist. And the Chinese herbalist went behind the desk and got this paper out and showed me all the things. So he said, this is a medicine that we use for nerves and high blood pressure. And I said, well, what's in it? He said, well, it's Lu Fo Mu root. So I had no idea what that was. So I said, do you know what's actually in it? So he said, yes, it's a Rauwolfia drug. So this medicine had Rauwolfia in it. Rauwolfia contains rezapine, which depletes dopamine in the brain and was integral to the dopamine miracle story. It won Carlson the Nobel Prize. So through the bit of Sherlockian detective work, by making the extra effort, I don't know what would happen now. Probably if I went outside the hospital with a patient, I'd have to go and see the managers or something. But anyway, in those days, it was possible to do these sort of things. So, and so we stopped that. I stopped his dopa. He came back again, cured. I've never seen a second case. I've always thought, well, I'm going to see another one of these cases. I've never seen another one. So I don't know how often this is used or still used in Chinese medicine, but I never saw another case. Now, just to finish the clinical bit of my talk, many of you, including me actually, when I was interested in tics, were grateful for Sir Michael Rutter's Child and Adolescent Psychiatry book. It's the go-to book for people training in adolescent psychiatry in the United Kingdom. But I want to show you this in a sort of slightly critical way. This is an example of the way of Sherlock Holmes thinking, which is not normal, and you have to work on it sometimes. You have to see things that other people haven't taken much attention of. So one of my friends, who's a Sherlockian too, a child psychiatrist, sent me these slides. And he'd noticed that in Sir Michael Rutter's book, there were, in 399 pages, the book is 1,000 pages long, there were 1,091 Rutters. Those are Rutters. So by the time you've read this book, you've been rutterized. And you may actually be suffering from rutterosis. but this is not the point. The point is that this academic psychiatry is about publishing and being recognized. It's not about real-world, real-time problems. And when you have somebody as eminent as Sir Michael Rutter, even if what he writes is done in a benign, well-meaning way, it becomes authoritative, and you are in danger of not challenging it. And what Dr. Goody, I think, was trying to teach me was that you need to get down and see patients, because in Sir Michael's book, there is not a single child. Not a single child is mentioned in this academic tome. So you're not going to learn how to deal with real everyday problems. So Sherlock Holmes can be used for devious strategies of that sort too. Now, I think it's probably true in psychiatry too, but in neurology, I think we're dealing with so many horrible illnesses that in order to avoid burnout and maintain curiosity and interest, I think research is really important. And I don't mean serious basic science research. I mean observing in the clinic, trying to answer the questions that our patients ask us and we don't know the answers to, through audit and clinical observation. This has become much harder to do in recent years. And in order, the person who's helped me with my research hat on, as Tim mentioned at the beginning, has become a sort of invisible mentor with whom I forged a Faustian pact, was William Burroughs. Now, I first intersected with him on the front cover of Sgt. Pepper's album in '65, where you can see him there next to Marilyn Monroe up here. There were all sorts of people on this: Lenny Bruce, W.C. Fields, Mae West, Edgar Allan Poe. And being a nerd at that time, I was a medical student, I wanted to know who all these people were. So when I first looked at the cover of Sgt. Pepper, I could only recognize about 20% of people. I mean, I knew who Charlie Chaplin was and so on, but only about 20%. So I looked them all up, and amongst them was William Burroughs. And I learned a bit about him, and I learned that he was a wife-killing homosexual. Homosexuality was illegal at that time in 1965. He was a heroin addict, and some people said he was a communist, and he was also a writer. So he was a kind of unlikely hero for a young aspiring doctor to take on. And in fact, I kept it pretty secret, even though it was the late 60s and it was a countercultural period. So I read Naked Lunch at a time when I was quite disenchanted with some of the things I was seeing on the wards at the London hospital at that time. Diva surgeons, the way certain psychiatric patients were being treated. So I went through a sort of period of disillusionment late on in my clinical career, and Burroughs kind of spoke to me at that time. And when I read Naked Lunch, I didn't really know whether to vomit or laugh with his emetic texts. And but the grotesque humor, and particularly his characterization of Dr. Benway, who was a doctor who lacked any conscience, the antithesis of a good doctor, an expert on all phases of interrogation, brainwashing, and control, who only deplored brutality because of its inefficiency in his brainwashing techniques. And it made me laugh, and although it was a caricature, although Benway was of course a caricature, none of my teachers were really like that, there were certain aspects of them that reminded me of Benway and made me laugh, and that kind of drew me in a little bit to Burroughs. And this is Burroughs playing Benway and also reading from his book. So I'll just show you a quick clip.
Nurse, I can't find his pulse, Doctor.
Dr. Manway.
So this is Burroughs with the...
Cardiac arrest, goddammit.
Adrenaline, Doctor?
No, the night porter shot it all up for kicks. Picks up one of those vacuum cups at the end of a stick they use to unstop toilets. He advances on the patient. Make an incision, Dr. Limp. I'm gonna massage the heart. Dr. Limp shrugs and begins the incision. Dr. Benway washes the suction cup by swishing it around the toilet bowl.
Shouldn't it be sterilized, Doctor?
Very likely, but there's no time. Watching his assistant make the incision, he sits on the suction cup like a cane seat. You young squirts couldn't lance a tempo without an electric vibrating scalpel with automatic drain and suture. All the skill is going out of surgery, all the know-how and make do. Did I ever tell you about the time I performed an appendectomy with a rusty sardine can? And once I was caught short without instrument one and removed an uterine tumor with my teeth. That was in the upper effendi, and besides, the wench is dead.
The incision is ready, Doctor.
Dr. Benway forces the cup into the incision and works it up and down. Blood spurts all over the doctors, the nurses, and the wall. And the cup makes a horrible sucking sound.
I think he's gone, Doctor.
Well, all the day's work.
I think it's enough. So, you know, for the punk generation who adopted Uncle Bill, it was his voice that got them. You know, the St. Louis drawl is an incredible voice. In fact, when I'm playing it at home, my wife starts saying, oh, you know, God, get that off. I can't stand his voice any longer. But anyway, so Burroughs encouraged my rebelliousness, which was not very prevalent in medical school in the 60s, even though the rest of the university students were going wild. I mean, we were still pretty conservative. And he led me, I learned he was on the faculty of this strange institution which had been set up in Shoreditch on Rivington Road called the Anti-University. And he was one of the faculty members. Other faculty members were David Cooper, who set up Villa 21 and was a leading light with Ronnie Lang in the anti-psychiatry movement of the 60s. So it was a kind of extension of anti-psychiatry and anti-establishment, the anti-university. So I'll just show you this clip, because I went to listen to a talk there.
Getting into the anti-university is mostly a question of finding out where it is. Down a narrow street in Shoreditch, your best point of reference is the little pub next door. Behind this unspectacular entrance is a movement which rather ambitiously hopes to change the pattern of university education. What they offer are new-style courses in contemporary arts, politics, and psychology. Inside, it's all a bit chaotic.
It's a qualitatively different thing than an establishment university. It's an attempt to bring together under one roof all kinds of things that are not permitted at established universities, or if they're permitted at established universities, aren't accessible to 95% of the population.
A psychologist in the movement, Dr. David Cooper, believes it'll spread
Dr.
much
Cooper,
further.
what precisely does the anti signify?
The anti signifies a basic change in the rules of the game, whatever game one's playing, whether this is in the context of a hospital, a certain art form, academic situation, but a basic qualitative radical change in the rules of the game, whereby the basic aim is to break down all false compartmentalizations, in other words, boxes that people get into. So we're concerned to break down academic boxes in terms of the total nature of the bureaucratic academic institution, false discipline compartmentalizations, and this extends to many other areas. The box of the bourgeois family, for instance. This has to be broken down so that children can relate to people outside the family much more freely than they do, so their parents can relate to other people outside the family box also. In fact, what we're aiming at is the breaking open or explosion of all boxes.
So, you know, Burroughs graduated from Harvard, but he found the course useless, so he developed his own curriculum while he was at Harvard. And he toyed after graduation with becoming a psychiatrist, and he enrolled at the University of Vienna just before the Second World War broke out. After I'd written my book and I got to know a lot of deadbeats and people who had known Burroughs personally, they told me that they'd all breathed a great sigh of relief when he dropped out after one term from his medical studies, as they were certain he would have killed hundreds of people if he'd become a doctor. So what my Faustian pact with Burroughs was nothing to do with being a good doctor and Sherlock Holmes. It was to do with the anarchy of science and teaching me how to navigate the roadblocks which are increasingly prevalent now in medical research. And I'll just tell you a little bit more about that now. So these are a couple of Burroughs quotes. The one I like more is, magic needs to be more scientific and science more magical. Of course, he, as a writer, he also said that the word was a virus, which reminds us that silence in medicine can be a great healing power. And even the most hallucinatory inventions of his imagination always seem to me to be grounded in very hard, clear, powerfully analytic and authoritative thought. For example, his writings on the many drugs that he subjected his brain to over decades. And he taught me, and he said to me sometimes at night, question everything, check your sources. Good journalistic advice. Avoid the emperor's new clothes syndrome, which still is very common in medicine. Even exterminate rational thought if it's required to do so. So, for example, he would ask you to question things like, what is the evidence that the brain has 100 million neurons? You know, how often do we all say the brain has 100 million neurons? What do you have some evidence for that? I mean, it's pretty slim. And then he really emphasized, and just read the quote while I'm talking, that creativity is being stifled by process, and that professionalism is being replaced with stupid accountability, reflected in things like league tables, performance indicators. He'd have if he was alive now, he'd have a field day, Burroughs. Everything that he talked about has become more that we all have to deal with now in our everyday work. And of course, he was a maverick and an individual. And I think one of the things that I worry about with the system bureaucracies, as Burroughs called them, is that it's squeezing out the little man. It's squeezing out the Patrick Steptoes, the Charnleys who developed the hip replacement in Wigan. You know, little maverick people who have done wonderful work. And the history of medical advances is littered with those people. Now you need a battalion of 1,000 people to do anything. You know, and I think there should be, I'm not saying that that's not good stuff, it is very good stuff, but there needs to be a place for the little man too, somewhere, somehow. Now, how did Burroughs actually influence my research career and help me? Well, I've told you how he helped me to sort of be quite suspicious about universities and control systems, and how if you're a scientist you have to dig in, and if you believe what you're doing is right, you have to stick at it. So these are a few of the things that I'll just talk to you very briefly about. So he, of course, self-experimented on himself, and he did it not so much in a hedonistic way, more in a way of curiosity, I think, because his writings about his drug experiences are quite objective. Now, so self-experimentation in the 80s, when I was doing a lot of clinical pharmacological research, was fine. You know, I mean, most of my teachers at UCH encouraged us to self-experiment. It was considered to be highly ethical. You know, if you're going to give a drug to a patient, and you know, it's appropriate that you should try it yourself. Why shouldn't you try it yourself, and why shouldn't you do clinical pharmacological studies on it? So when we started with using Deprenyl, the selective type B monoamine oxidase inhibitor in the late 70s, this was me, patient 1. We took Deprenyl for a week, then had a load of tyramine challenges, but we also measured our platelet MAOs and our urine phenylethylamine. So these sort of experiments were encouraged in the 80s, and I think are very difficult to do now. Editors refused to accept these papers. Ethics committees blocked them on the grounds that the results are biased and subjective, and also that the investigator is putting himself at unnecessary risk, as if the patient wasn't putting themselves at risk. So it's much more difficult to do these kind of studies now, which is why patient groups are arming themselves and doing them themselves. So you get informed patients, often with a mentor, helping them to do it outside university ethics committees, which I think is terrible. I mean, this should be done within the university, really, it should be done. So that was the first thing. And then when we were looking for treatments to manage the capricious oscillations that occur on L-DOPA after several years of treatment in Parkinson's disease, I remembered that Burroughs had been treated in London in the 50s by John Dent with apomorphine to reduce his craving. At that time, it was not known that apomorphine was a dopamine agonist, but Dent thought that apomorphine was not just an aversive therapy, that it worked on the back brain as a metabolic regulator. And Burroughs became an unlikely champion for apomorphine. He had very little success in persuading the FDA or the Narcotics Bureau in the States to test it, but he remained faithful to it despite lapsing and going back on junk. He still felt that it was the most effective treatment he'd ever had to help his acute craving. And as a result of coming off apomorphine in London, he was able to finish and write Naked Lunch. So this is Burroughs just being interviewed.
That's William Burroughs in Junkie.
Yes. And I would question that statement now. At that time, I had not taken the apomorphine cure, which was the way I finally got off junk, was through apomorphine, taken with Dr. Dent in London. And after that cure, I would question that statement, whether there is a permanent cellular alteration.
So something came to me of Burroughs and apomorphine when we were looking around for new dopamine agonists. And I think I have to thank him a little, because my role in the reintroduction of apomorphine pump therapy to treat advanced Parkinson's disease is the most significant achievement in my career, because of course I didn't discover apomorphine, but I got it back, and it's of course still being used. It's on the NICE guidelines, and to be able to actually be a part of introducing a new treatment is most doctors' dream. So I have to thank him for telling me, why don't you try apomorphine? And then so this was the late 80s, and then we went to the beginning of the new millennium, and a patient's wife came up to the clinic and said, "Professor Leach, the medicine you've given my husband has turned him into a junkie, a drug addict. He's behaving like a drug addict." And I couldn't get my head around this, that L-DOPA, a naturally occurring amino acid, could be causing a dysregulation that would lead to craving, abuse, and overuse of a medicine used to treat neurodegenerative disease, and for which, as far as I knew, there was no street use. So it wasn't L-DOPA is not a street drug. So it wasn't like painkillers, opioids, or some of the psychotropic drugs. So I found it very difficult to believe what she was telling me. And then, of course, as happens always in medicine, you hear some more cases and the penny drops, and then you start to do things. So Gavin Giovannoni and I wrote this paper up. We were very in the JNNP, and we used this term pinched from the biological psychiatry literature from George Koob, really to avoid using the word addiction, because the last thing we wanted was newspaper headlines saying miracle drug for Parkinson's disease causes drug addicts, and the most effective treatment that I think has occurred in my generation of neurologists would be withdrawn from the market. We were really terrified of that. And of course, this is a rare complication. It only occurs in about 1% of patients, mainly young men. So I had to get to know about drug addiction. I knew nothing really about drug addiction. We'd not even had a single lecture on drug addiction in the medical school curriculum. So I contacted Jenny Byrne, who was working at the Bethlehem, and she gave me a few tutorials. And I tried to read the literature on addiction, particularly the biology of addiction. And of course there were exceptions. There were some excellent papers, but by and large I found it incomprehensible as a neurologist. I couldn't understand it. I couldn't understand the terminology. I couldn't read it, so it didn't stick. Nothing much stuck. So I went back to read Burroughs again, Naked Lunch, Junkie, and Burroughs said that addiction is a metabolic illness, and it's no more a police problem than tuberculosis or radium poisoning. And he was also very against methadone, so he said to say a heroin addict has been cured by methadone is like saying an alcoholic has been cured of whiskey by the use of gin. So he didn't see this as the eventual solution to the management of addiction. Of course, it can be helpful and it's useful. But much more importantly than that, he anticipated, if you read his text very carefully, he anticipated modern theories of addictions. For example, Berridge and Robinson's incentive sensitization theories of wanting, not liking. Burroughs said that heroin, he craved heroin and he desired it, but he didn't like it. And he also, as you see in this quote, he described reinstatement, so that, it takes you most people a few weeks or months to get hooked on heroin. But even if they've been off it for 10 years, they have another shot, the sensitization remains. It doesn't disappear, and this is, of course, standard psychiatry now and teaching. So he knew that from his own writings and his own experience. So I suppose what I'm saying is that sometimes pathographies written by patients can help us as doctors to understand things that textbooks may not always do. And he helped me in many ways. I don't think he got it all right, because Burroughs said also that anybody could become a drug addict. If we were all kept here for 3 months and given heroin every day, we'd all become junkies. Well, I'm not sure that's totally true. I mean, there are obviously individual susceptibilities to these things. So that was his third bit of help in my clinical research. And then the last one is the most recent, which is through the dream machine. Now, Burroughs and his friend, the artist Brian Geisen, developed a machine which I'll show you, which depends on flicker to produce hallucinations without drugs. So Geisen had been traveling in France through a line of poplars, and the light had been coming through, and he'd seen a lot of incredible geometric constructions of incredible intricacy, which were sort of built up from a multi-dimensional mosaic into living fireballs. And he described this. And then with Ian Somerville, the machinist who was a friend of theirs, they devised this machine called the Dream Machine, which I'll show you on the next slide, which they believed would replace television in the 60s. So they tried to get a contract with Philips, but unfortunately somebody who was using the Dream Machine had a photosensitive epileptic seizure, so Philips called it off. And they also sold it to Helena Rubinstein, the perfume maker and fashion. And it was for a while flashing in the Rue de Rivoli in Paris as a decorative feature in her shop. So I've got a dream machine in my office. This is my dream machine. It's basically a turntable rotating at 78 revs per minute, which generates a flicker like alpha rhythm between 8 and 12 hertz. And you sit about 30 centimeters from it with your eyes closed. And most people see colors and shapes. And a few people see complex visual hallucinations, but not many. It's usually geometric, simple hallucinations, and Dominic Fitch may talk more about these sort of things later. But we decided to do a little experiment looking at visual hallucinations in Parkinson's disease. So we picked 15 patients who have never had visual hallucinations. As you know, people with Parkinson's disease, up to 70% of them experience these at some point. They're complex visions of animals and people, usually, rather than the simple hallucinations that traditionally occur with flicker. But we were interested to look to see if flicker could induce them in people who had visual hallucinations, not psychotic hallucinations, but non-frightening visual hallucinations in the past. So Angela Zarkali and Ramona Weil, who's talking tomorrow, I think, here, set up this experiment using a strobe based on the dream machine, which you've just seen running, and also transcribe the flicker onto a computer screen, so that if we were able to see complex hallucinations occurring in these patients, we could do functional MRI. The study was negative, unfortunately, so I can't tell you some very exciting results. 4 of the 15 patients in each group experienced hallucinations, and 1 experienced complex hallucinations, but basically we didn't see any generation of the visual hallucinations that the patients had. But anyway, it was worth an experiment. Now, those of you who are concerned about what's happening in healthcare should definitely read Burroughs' 1979 book, which I call a nut graph. It's not really a book, it's not really a novella, it's a sort of, a nut graph is editorial slang for a paragraph or sentence that summarizes what a story is about without divulging every detail. So it was a sort of preliminary film script, and Burroughs ripped the title off from Alan Nurse, a doctor who had written a book called Blade Runner, and Ridley Scott bought the title off Burroughs for the adaptation of Philip K. Dick's novel for the famous films Blade Runner. So it's a complex story of that. Now, Burroughs very strongly believed that the healthcare business was ripping off its customers, and that science in some ways was damaging the art of healing, perhaps indirectly. So he was very concerned about that, and he writes about this in this short book, which you can read in an hour or two, about New York becoming an underground center for alternative medicine, because the healthcare system has become so rigid and bureaucratic that you could only get treatment if you agreed to be sterilized, because the government were concerned about an epidemic of hereditary disorders occurring in elderly people, such as diabetes, Parkinson's disease, and Alzheimer's disease, and that the government had set up this control system that sterilization was mandatory. So I would, this was also an interesting book that I've read, and I suppose has touches of Ivan Illich in it and so on, and made me think about medicalization and those sort of things, which I would recommend that you consider reading. So this is my last slide now, and this is some advice really from Burroughs, which I think for those of you who are just embarking on your careers in psychiatry or neurology or neuropsychiatry is, I think, good advice. Build a good name, keep your name clean, don't make compromises, don't worry about making a bunch of money or being successful. Be concerned with doing good work and make the right choices and protect your work. And if you build a good name, eventually that name will be its own currency. So I don't really expect any of you to adopt William Burroughs as your invisible mentor. But what I would encourage you to do is, if you have first of all, I would encourage you to have an interest outside medicine. And try to make that interest outside medicine impinge on your everyday medical research. So if you're interested in atomic physics, use it in your medical work. If you're interested in collecting butterflies, use it in your medical work. And this is it's a special type of serendipity called alter mirage, which has played a very important part in many interesting medical developments. So I think that's how Burroughs' writings have helped me, really, as a sort of alter mirage phenomenon. Thanks very much.
Great, thank you for a fascinating talk, Andrew. So we've probably got time for one or two quick questions. There are some microphones going around, so if you've got a question, put your hand up and keep it up so the microphones can get to you.
Slightly boring question after a fascinating lecture, but the frequency of flash that the dream machine produces exactly overlaps with the frequency required for photosensitivity, which is about 17 or 18 cycles per second. So it's interesting that that frequency should excite other things in the brain apart from seizures.
Yeah, Burroughs was always very keen to collaborate with neuroscientists, really, and when they started the dream machine work, they went to try and see Gray Walter at the Burton, who was working on, had written The Living Brain and so on. And it's not clear whether Gray Walter ever actually saw them, but he and Geisen tried very hard to collaborate, but Burroughs was always trying to forge collaborations with doctors and scientists. He would have liked that. I mean, but he of course had a lot of difficulty to do it, but he always wanted to do that because he was always interested in medicine. And in a way, he saw himself as a kind of witch doctor.
One more quick question if there's anyone.
Thanks. I've always wondered what levodopa would feel like for someone who's not got Parkinson's disease. Have you ever tried it?
Tried what?
Levodopa.
Oh, yeah, I have. I've tried all the medications that I use. I was violently sick with L-Dopa. Apomorphine was much nicer. I won't tell you what happened, but and selegiline was even nicer. To be on a monoamine oxidase inhibitor for a week was great. Yeah.
Okay. On that happy note, we'll draw to a close. So thank you again, Professor Lees, for an amazing talk.